First of all, I would like to thank you, Sophia, for the kind invitation and for everyone here. It's a pleasure to be here to join the conference. And I was giving an appealing title. It's Pulmonary Hypertension and Sleep Disorder Breathing, No More Strangers in the Night. And there is indeed a close interaction and interplay between pulmonary hypertension and sleep disorder breathing. But it's important to distinguish between sleep disorder breathing that may exacerbate or lead to pulmonary hypertension, also pre-capillary pulmonary hypertension, WHO group 3, pulmonary hypertension due to or in the context of hypoxia. And this is obstructive sleep apnea, obesity, hypoventilation syndrome that I would like to mainly discuss. Most of you know that obstructive sleep apnea, this is a bit challenging to discuss the association with pulmonary hypertension. And then, of course, sustained hypoxia during sleep or hypoxemia during sleep in hypoxic patients such as COPD or ILD is also an important connection to pulmonary hypertension, WH group 3. And the second part will be dedicated to pulmonary vascular disease. This means pulmonary arterial hypertension, so WH group 1, and chronic thromboembolic pulmonary hypertension group 4. And the pulmonary vascular disease itself also leads to sleep disorder breathing, and this is mainly sleep-related hypoxemia, but we also see a higher prevalence of obstructive sleep apnea in patients with pulmonary vascular disease. Not so important anymore in these days where we have good treatments is central sleep apnea with periodic breathing in these patients. Short question to you, who is treating regularly patients with sleep disorder breathing? I guess many. Who is treating patients with pulmonary arterial hypertension on a regular basis? Okay, this reflects the prevalence of the disease quite well. So the prevalence of obstructive sleep apnea in the general population, of course, it depends on the definition, but we can say it's more than 20%, but prevalence of obesity hypoventilation syndrome in the general population is roughly 1%. However, the prevalence of pulmonary arterial hypertension is less than 0.01% of the general population. But still, independent of in which field you work, we should be aware of this interplay and the interaction, and sleep disorder breathing is always a treatable target in both positions. When we think about the mechanisms of how, when we start with the first part, so sleep disorder breathing leading to or exacerbating pulmonary pre-capillary pulmonary hypertension. And when you think about the mechanisms in OSA, it's intrathoracic pressure swings, it's intermittent hypoxemia, and the increased sympathetic activity, but there is also some vascular remodeling. And the prevalence of pulmonary hypertension in pure obstructive sleep apnea is not high. So most patients, as you will see soon, that have daytime PH that persists, they not only have OSA, but are hypoxemic also during the daytime. And in obesity hypoventilation syndrome, we also have intrathoracic pressure swings, intermittent and sustained. That's the difference, hypoxemia and vascular remodeling and a very high prevalence of pulmonary hypertension. So here you see how obstructive sleep apnea increases sympathetic activity. You see a 2-minute extract of sympathetic nerve activity, respiration, 2 obstructive apneas, and you see how sympathetic activity increases and peaks at the end of apnea or at apnea termination, and you see how the systemic blood pressure increases. This is an extreme increase with systolic blood pressure going higher than 200 millimeters of mercury. But it's not only the case that systemic blood pressure increases during obstructive apneas, but also the pulmonary artery pressure. And this you see here in a phasic REM, 10-minute extract or so. You see here the pulmonary arterial pressure significantly increasing also at apnea termination, together with the systemic blood pressure. And you see it in more detail here, what happens. One obstructive apnea, no flow, but continuous respiratory effort. And you see here the esophageal pressure. And you see at the same time, together with this intrathoracic pressure changes with the respiratory effort, how the pulmonary arterial pressure and the right atrial pressure increases up and down, but you also see a slower increase of the pulmonary artery pressure, and this is associated with the decrease in oxygen saturation. This is better illustrated here in an important publication from Palermo from more than 30 years ago. You see two types of changes of pulmonary artery pressure in obstructive sleep apnea. The short pressure changes in the transmural systolic pressure in the pulmonary artery in association with the intrathoracic pressure swings, and then the other, the slow change over a longer time or slow increase in pulmonary artery pressure. This is due to the hypoxic pulmonary vasoconstriction with the deoxygenation. When we think about the mechanisms of intermittent hypoxemia versus chronic hypoxemia or hypoxia, we can see this from a mice study that compared to normoxia, intermittent hypoxia, and they were exposed to 2-minute cycles of 10% versus 21% of O2 for 8 hours per day over 4 weeks. This resulted in a significant increase in right ventricular pressure, but not as much as chronic hypoxemia if they were exposed to 10% O2 or FeO2 0.1 for the 4 weeks. And one of the mechanisms is vascular remodeling. This you see here. You see the vessels and the muscle staining and how much of these myosin positive vessels you see per high power field in the microscope. You see that there is a significant increase of this muscularization also in intermittent hypoxemia. So when modeling obstructive sleep apnea, not only chronic hypoxia. So if we try to answer the question whether obstructive sleep apnea leads to PH, we can say from these right heart cath studies that obstructive sleep apnea leads to intermittent increases in pulmonary artery pressure due to intrathoracic pressure changes and due to hypoxic pulmonary vasoconstriction with a decrease in the oxygen saturation. But in most patients, the PAP, the pulmonary artery pressure, normalizes again when they wake up in the morning and don't have sleep disorder breathing anymore. The prevalence, when we look at different studies with OSA, different cohorts, is lower than 20%. But this also means there are some patients with OSA, with severe OSA, that have PH as a consequence of that. And it has also been shown that CPAP or treatment of obstructive sleep apnea improves pulmonary hypertension. Then the second question is, does it lead to sustained PH? So PH during the daytime, real PH, and here we also have a few studies that show this roughly 20% prevalence. But when looking at the patients in more detail, we see that most patients, or two-thirds, were also a little bit hypoxemic during daytime, and half of them had hypercapnia during daytime. So most have an underlying restrictive disease or COPD. When we look at the predictors of who with obstructive sleep apnea is likely to develop sustained PH, it's those with mild daytime hypoxia with a higher BMI. So obesity is an important factor, and those with lower forced vital capacity. So what about OHS and pulmonary hypertension? Does obesity hypoventilation syndrome lead to pulmonary hypertension? Here we can clearly say yes, and you see this when you consider the prevalence of PH in obesity hypoventilation syndrome. You see different studies and cohorts. The prevalence is somewhere between 50 and 80%, so very high. And also from these cohort studies, we know that those with lower daytime arterial PaO2 and those with higher body mass index are at highest risk to develop PH and right heart failure. Here just the definition briefly of obesity hypoventilation syndrome. You have to be obese, you have to have daytime hypercapnic respiratory failure, and shouldn't have another cause responsible for hypoventilation. And when we look at OSA cohorts, we see that around 10 to 20% of these patients actually have obesity hypoventilation syndrome, and the prevalence is even higher in hospitalized, very obese patients. And 90% have obstructive sleep apnea. About 70% have severe obstructive sleep apnea. There are different relevant aspects of obesity on respiratory mechanics, ventilation, a decrease in ventilatory drive, and gas exchange problems also due to ventilation-perfusion mismatch. And this then results not only in sleep disorder breathing, which is OSA and sleep hypoventilation, but also daytime hypercapnia and hypoxemia. And it's a continuum from obesity over sleep disorder breathing to daytime respiratory failure. And then what we are talking about now is right heart failure, the secondary disease. Here, the important thing is to understand the type of sleep disorder breathing, to select the proper treatment, the periods of hypoventilation and the periods of pure obstructive sleep apnea. And here you see the continuous increase in addition to these hypoventilation periods of CO2. So a proper sleep study is always needed to select the right treatment. And it's really important to treat sleep disorder breathing to improve outcome in these patients and to normalize ventilation during daytime. And here you see the difference between the mortality in post-hospital discharge in hypercapnic obese patients compared to eukapnic obese patients these were age and sex matched data. So there is a huge higher risk in mortality in those with OHS compared to eukapnic obese, and it's mainly due to right heart failure. We can treat obesity hypoventilation syndrome effectively with either CPAP or non-invasive ventilation, depending on the type of sleep disorder breathing and the situation, whether we see them in a stable condition or in acute, on the ICU with acute and chronic respiratory failure. So what happens with pulmonary hypertension if we treat sleep disorder breathing in obesity hypoventilation syndrome? Here you see data from the PICWIC study, these randomized controlled trials on CPAP versus NIV in patients with obesity hypoventilation syndrome with severe OSA. And you see that independent of whether you treat it with CPAP or NIV, as long as it's an effective treatment for obesity hypoventilation syndrome, systolic pulmonary artery pressure, here assessed by echo, improves. It does not normalize completely, but it significantly and clinically relevantly improves. This is another study. There are very few data on this. And this is a study with 16 patients, only OHS, or some were also with COPD. And you see that the cardiac index is stable, but you improve with NIV the pulmonary artery pressure and therefore the pulmonary vascular resistance at our actual target of interest. So let me summarize for you the association with sleep disorder breathing with pulmonary hypertension WH group 3. So we know that all patients with suspected precapillary pulmonary hypertension due to sleep disorder breathing or hypoxic hypercapnic lung disease should undergo a sleep study, as the treating sleep disorder breathing is essential, or it's a key element to improve pulmonary hypertension. We know that obstructive sleep apnea leads to intermittent nocturnal pulmonary hypertension, but some proportion also has sustained pulmonary hypertension. And these are mainly those with those with daytime hypoxemia and hypercapnia. We have also seen that pulmonary hypertension is very common. We have a high prevalence of PH in obesity hypoventilation syndrome, and that these patients have worse outcomes compared to eukapnic obese patients, mainly due to right heart failure. And if we treat sleep disorder breathing and respiratory failure, we improve PH. So it's not the pulmonary artery pressure we want to, or the resistance we want to target with drugs, but we have to treat respiratory failure and sleep disorder breathing. And right heart, the core pulmonale that you see here from an autopsy, this is reversible. Right heart failure is reversible very fast if we treat sleep disorder breathing. Then we come to the second part. This is sleep disorder breathing in patients with pulmonary vascular disease, pulmonary arterial hypertension, or chronic thromboembolic pulmonary hypertension. Here you see from a study from our department with 63 patients with either PH or CTEPH, with a daytime SpO2 of 95%, so not normal, but not severe hypoxemia, and that they had a relevant proportion had nocturnal hypoxemia. So the 77% spent more than 10% of the night with SpO2 lower than 90%, and half of the patients spent more than half of the night with SpO2 lower than 90%. And we concluded that nocturnal hypoxemia is first thing is it's very common in patients with pulmonary vascular disease. And the second thing is that it's underestimated if we only assess daytime hypoxemia, if we do blood gases only during the daytime. And we also saw that nocturnal hypoxemia is associated with disease severity when we assessed hemodynamics. The more hypoxemic during sleep, the more time below 90, the worse the hemodynamics. This is an important study from the American colleagues with almost 200 patients with pulmonary arterial hypertension, so group 1, who looked at transplant-free survival over a follow-up of 2 years. And here we saw that the AHI, apnea-hypopnea index, and the time below 90 were associated with the higher they were, the lower the right ventricular ejection fraction. But T90 was the time below 90 during the night was a much stronger predictor of adverse outcomes. So T90 was associated with the higher right ventricular systolic pressure, pulmonary artery pressure, and hypertrophy of the right ventricle, and particularly with transplant-free survival. So the higher the T90, the lower the transplant-free survival, and this was particularly in the subgroup with idiopathic pulmonary hypertension. We can treat sleep disorder breathing in pulmonary vascular disease. Either we only have sleep hypoxemia, then we need nocturnal oxygen, of course, or if we have OSA, we can treat OSA with CPAP, MAD, or most often it's a combination if patients have OSA and sleep hypoxemia. And I will finish with studies. I hope I'm still in time. All right, yeah, then I can do it. So first study is a randomized controlled trial on nocturnal oxygen versus placebo from our department. We randomized patients for 5 weeks to use 3 liters of oxygen or placebo air during the night, and if they wanted, also during resting periods during the daytime. The patients had pulmonary arterial hypertension, group 1, or half of them distal chronic thromboembolic hypertension. And we saw that oxygen versus placebo improves daytime performance, so the 6-minute walking distance and quality of life in these patients. And most used it only during the night. Then we also looked at another potential treatment to improve oxygenation during sleep, and this is acetazolamide, the carboanhydrase inhibitor acetazolamide. This was a randomized crossover trial where patients also for 5 weeks, instead of oxygen, they received twice a day acetazolamide. And we saw, you see this better illustrated here in the graphs, that this significantly improved the mean nocturnal oxygen saturation by more than 2%, and decreased the time below 90 by around 20%. And we increased the number of patients with a mean nocturnal oxygen saturation higher than 90% from 45 to 85%. And remember, you just saw that this is an important predictor for long-term outcome for mortality, so the time below 90. So this was also an effective treatment, not as effective as oxygen, but for certain situations it might be an option, and it was also safe. And acetazolamide also had an effect on the apnea-hypopnea index. It has an effect on the loop gain, and these patients had, as you saw here, not severe obstructive sleep apnea, but the baseline AHI was 12 and supine AHI was 35, and this not too much, but it decreased a little bit as well. So you address both. You address obstructive sleep apnea if it's only mild, and you address nocturnal hypoxemia with acetazolamide as well. So the summary on sleep disorder breathing in patients with pulmonary vascular disease is that we have to be aware that we have a very high prevalence of sleep-related hypoxemia that is very much underestimated if we only measure oxygenation during daytime. So sleep studies are also recommended. And because patients often have also obstructive sleep apnea, it's recommended to do a proper sleep study, not just look at, not just use oximetry if you can, but oximetry is better than nothing, I suppose. And the prevalence of sleep apnea is also higher than in the general population. And nowadays we mainly see obstructive sleep apnea, not so much periodic breathing anymore. And sleep disorder breathing is also an important target to improve outcome. If you think back of the American study with the mortality time below 90 in patients with pulmonary vascular disease. And with this slide from the Swiss mountains, I would like to thank you.